evening, everyone. I hereby welcome you all, and we take great pride and pleasure in bringing you this educational program, Advanced Classes in Dentistry, Virtual Class 2. This program shall be conducted with our esteemed speaker, Dr. Hussain Basma. This educational program is brought to you by FDC Limited, makers of Flemiclav. Therefore, on behalf of FDC Proxima, greetings to everyone. As you know, FDC is a fully integrated pharmaceutical company. Today, FDC carries forward the flaming spirit of its first dream, achieving accreditations from the US FDA, UK MHRA, MCC RSA, and the UAE, to cite a few. For over a decade, FDC is very strong in building capabilities of antibiotics, including the illustrious brand Flemiclav, a brand of co-amoxiclav. FDC has also set up globally approved multi-location manufacturing facilities for active pharmaceutical ingredients, as well as finished dosage forms. FDC markets more than 300 products in India and exports many of these to over 50 countries. FDC strives to explore, innovate, and integrate solutions with modern technology, empowering talent and expanding healthcare horizons for a better quality of life to millions globally. Now I take this opportunity to introduce and welcome our esteemed speaker, Dr. Hussain Basma. Dr. Hussain Basma received his Doctor of Dental Surgery from Damascus University in 2009 with a full scholarship. Dr. Basma completed a residency in prosthodontics at Lebanese University and received a certificate in periodontology and Master of Science from the University of Alabama at Birmingham. Dr. Basma is a diplomat of the American Board of Periodontology, lectures nationally and internationally about periodontology and dental implants, and is a dental social media influencer. Dr. Basma is an assistant professor in the Department of Periodontology at UAB. His research and teaching efforts focus on bone augmentation, full arch rehabilitation, multidisciplinary care, and integration of technology. It's an honor to have him with us on this platform. I now request Dr. Basma to enlighten us on the topic of incision, designs, and flaps. Over to you, Dr. Basma.
Awesome. Thank you so much for the kind introduction, Dr. Gulshan. And before I start, I always like to thank Spirant, represented by you, Dr. Gulshan, and by Dr. Manish Varma, for their kind invitation and for allowing me to represent all the different topics that we do here at the University of Alabama. Again, thank you so much for the kind introduction. And for those who are joining us for the first time today, I would like to, as Dr. Gulshan mentioned, that I'm originally from Lebanon. I am a full-time assistant professor, board-certified periodontologist at the University of Alabama at Birmingham. And before I represent I give a lecture on any topic, I would like to thank the UAB team for allowing me to represent them as I'm lecturing. If there is going to be a Q&A, and thank you so much for everyone who have reached out after the lecture if they had any question last time. But if you had, we're going to have a Q&A session at the end of the presentation. However, if you feel that there is one question that you wish you asked or you didn't have the time to ask, please feel free to reach out to me via my social media account, via my email account, or via my website. So today's presentation is about the fundamentals of periodontal surgery. We're going to be talking about incision designs and flaps. And it is a very important topic to understand because every single procedure that we do in our practice has its own design. If we do a sinus lift, if we do an extraction, if we do an extraction of a third molar, if we do an implant placement, if we do soft tissue graft, every one of these procedures is unique. And there is a certain type of incision design, there's a certain types of flaps that we should utilize in order to have predictable outcomes. Okay, so in today's presentation, we're going to talk about different types of flap designs, how, why, and when to use each flap design, okay? And then we're gonna talk about the different incision designs that we have, okay? And then we're gonna talk about some surgical principles and conclude with some discussion questions and with a conclusion. So the whole essence of this presentation is going to be focusing on how to understand various flap designs and incision designs, when to use, and how to utilize it in order to have good and predictable long-term outcomes. So let's start first by flap designs. So when we talk about flap designs, we're talking about various things that we're gonna cover in the following slides. So let's take this case, for example, okay? This is a patient who presented with a fistula or a sinus tract on tooth number 8. And I would like to acknowledge Dr. Sharif Saeed for his kind offering of some cases that I'm gonna be presenting in the slides. So in this case, we are extracting tooth number 8. 100% I agree with everyone who would say, well, we always talk in literature about flapless surgery, okay? In this case, we had a fistula, we had to clean, we had to place a membrane, we had to place a bone graft, and then we have to do what? We have to come back and place our implant. But Dr. Basma, this is very important. Why? Because it's an aesthetic zone. Would you be willing to open a flap? Well, what kind of flap I feel comfortable in opening a flap in the aesthetic zone? Because it's what works and fits the aesthetic zone will definitely works and fit the posterior zone, right? So if I want to take this tooth out, the first flap I would definitely do is to do an intrasulcular incision on that tooth and the adjacent two teeth next to those on the mesial and on the distal side, and without any vertical incisions, and basically reflect the flap, take the tooth out, and place a membrane and bone graft and close it back. Why did I use this sulcular flap? Basically, all what I'm caring about here is to have a minimal access to the site and a minimal access to be able to clean the site well and to place my membrane and close it back. So I don't want to have a huge access. And I want, because it's an aesthetic zone, I want to try to limit the amount of flap elevation I'm doing here, because I know after every flap elevation, there's going to be a little bit of remodeling that could happen in the papilla, or a shrinkage that could happen in the papilla. And I hate to have that in the aesthetic zone. So in order for me, in some cases, to be able to have predictable access to the site, yes, we have to have a minimal incision design. You can say, well, in some cases, we don't have even to open a flap. All what you have to do is to clean the site and create a pouch and place a membrane. I agree with you, but here is the example of what a sulcular flap is. So I utilize a sulcular flap. Basically, a sulcular flap is couple intrasulcular incision that I place around the teeth on the cervical part and reflect the full thickness flap. So when do I utilize such kind of flap design? I utilize it in cases where I have, again, minimal access. Like if I'm taking this tooth out, for example. For example, if I want to just place an implant in this case, right? I open a flap, I do my crestal incision, and then I place my implant and I close it back, right? So what is the limitation of this flap design? Is that it's because it's very minimal, it's sometimes difficult to advance the flap due to lateral attachment, because on both the mesial and the distal end where my incision is stopping, this is where the flap is attached still. So I don't have a good manipulation of the flap if I want to advance the flap while I'm suturing it. So as a summary for this flap design, when do I use the sulcular? What is the sulcular incision? Is basically the sulcular flap, I'm sorry. It's an intrasulcular incision around the teeth or a crestal incision in order to lift the flap minimally, do whatever I want in that site and close it back. Then, but Dr. Basma, what if I want to advance? What if I'm doing a GBR here? What should I do? And at the same time, I don't want to place vertical incisions. And we're going to talk about vertical incisions in just a little bit. So because I don't like, Dr. Basma, to place my incisions in the anterior zone, vertical incisions in my anterior zone, because that might create some scar tissue if there is no keratinized tissue, what should I do? Well, what I can do here is basically extend my intrasulcular incision, including more teeth. What does that mean? That means by including more teeth in my incision design, now I am allowing for more relief of the flap that will allows me also to the ease of manipulation and advancing the flap that the sulcular flap, the minimal sulcular flap that we talked about earlier, doesn't let us do, right? So the whole purpose here is if I want to have more access, yes, I sometimes include more teeth and then have a better advancement and manipulation of the flap. When do I do this? Let's say I'm doing a very minimal, I'm placing an implant and I'm doing a minimal bone grafting there. So what should I do? I include more teeth and then I place my implant and put a bone graft and put a membrane and I advance it gently and not much to have a full or a passive closure. But Dr. Basma, what if I want to have more release? What if I'm doing more vertical releasing incisions or more advancement or bigger augmentation? What should I do? Well, in these cases, we have to move into different types of design, types of flaps, okay? Because here, the advantage of the sulcular flap, if you include more teeth, yes, you can have more advancement, you can have better access to the site, but still on the sides where you see the big blue arrows, okay, here it's still not very flexible, so it's still attached there. So you have minimal access to the most apical portion of the flap. Okay, so what should I do? What should I do in case we need more augmentation? Now we have to include a vertical incision. What is the vertical incision? Is basically what you see on the left image, on the most left part of the screen, right? I'm doing intrasulcular incision around the teeth and I place a vertical incision. And this is more preferably when I have a good amount of keratinized tissue, because keratinized tissue doesn't lead to scar tissue. I like to do that when I'm doing what? When I'm doing a bigger augmentation and I want more access. Then I start utilizing the pyramidal flap, or what they call it, the triangular flap. Basically, I do intrasulcular incision and I place one vertical incision. And usually, to talk a little bit about this vertical incision has to be always on the line angle of the tooth, adjacent to the site. Why do I do that? Is basically because I don't want to place it in the middle of the tooth, because that could lead to recession. And I don't want to place it in the middle of the papilla, because that might lead to some shrinkage of the papilla. So again, as you see in this tooth, my vertical incision should, on the lateral right here, should always be on the line angle. Avoid placing that vertical incision in the middle of the tooth, straight buccal of the tooth, or in the papilla. So in this case, I want to take this tooth out and then place an implant, and I'm going to do a bigger augmentation, and I'm adding soft tissue in order to have or to be able to create a papilla. And once I do that, I'll be able to do what? I'll be able to advance the tissue and to cover it, and I have predictable outcomes. Well, this happens if I need this amount of what? This amount of augmentation. I include more vertical incision, one vertical incision, and then because the flap is still attached on the other central, on the other end where we don't have a vertical incision, you still have a limited access on that end of the flap. So what should I do if I need a bigger augmentation, then my go-to is the trapezoidal flap, where basically I utilize 2 vertical releasing incision, and this will allow a better access. This will allow more advancement, a more passive closure of the flap, and more predictable outcome of augmentation. Like in this case, what the patient presented with a vertical defect. Vertical cases or vertical augmentation cases, they requires more advancement. They requires more pulling of the tissue, and it's very risky. If anything happen or there's more tension of the flap, what's going to happen is that there is going to be an exposure of the membrane leading to unpredictable outcomes. So what do we do in this case? Basically, we utilize 2 vertical releasing incisions on both ends of the flap. If we have good keratinized tissue, here we utilize a non-resorbable barrier, which is a non-resorbable barrier that we have to access and to remove after 6 to 9 months of healing of that bone graft. We put the bone graft in, and then we stabilize the membrane. You can see this is called EPTFE membrane, and then we close it back with a tension-free closure. How were we able to do that? Is basically by placing 2 vertical incision, because that will free the flap on both ends, leading to better manipulation, to more access to the site, and to ease to advance the tissue. Again, those vertical releasing incision, as you see on both the central and the lateral that we placed, they have to be on the line angle. They are not supposed to be on the straight buccal or on the papilla. So as a summary of everything I already talked about, if I have let's say I have a minimal, I want to place an implant. What should I do? Well, Dr. Basma, I can only do a sulcular flap. Yeah, that's enough. You open, I place my implant, and I close it back. Well, what if the site is a little bit deficient? Then we have to place an implant. We might include more teeth. Personally, I like to drop a vertical all the time if I'm doing any kind of augmentation. If one vertical incision is not enough, I do the second vertical incision, and that will give me a better access to the site and more ease to manipulate the flap. What if I'm doing a sinus lift, Dr. Bas? Well, if I'm doing a sinus lift, most of the time my window is a little bit more apical, right? So if I do one vertical releasing incision on the distal or on the mesial, the other side that I didn't place a vertical releasing incision will have more tension and will be very prone to a lot of pressure on the flap. So what I do in all my sinus augmentation cases, I like to place 2 vertical releasing incision. That's not going to hurt. Definitely it's going to help during the procedure. And for your information is that those releasing incision usually heals very fast. So I like to use some, we're going to talk about sutures the next time. So, and we'll go over what do I like to use whenever we do the vertical releasing incision versus the crestal incisions. Okay. So we talked about the different kinds of flaps that we use, right? We talk about the sulcular, the triangular or the pyramidal. We talked about the trapezoidal, okay? But now we move into the other part, which is basically how do we classify those flaps that we're talking about, right? Because sometimes we have a flap that we're opening a full thickness, or we're opening completely, or we're keeping a periosteum. So basically, are we exposing bone after flap reflection or not? What is the classification of flap designs after placement of the flap after surgery? We talked about osseous surgery, for example, last week. We're going to talk about all of these classification based on bone exposure after flap reflection, based on placement of the flap after surgery, and the management of the papilla. And let's start with the first one. So bone exposure after flap reflection. What does that mean? Well, there are some cases where we want to expose bone, right? Fully. We don't want to leave any periosteum on the bone because we want to have access to the bone. What are these procedures called? Those are called a full thickness flap. What does a full thickness flap means? A full thickness flap means that I'm opening a flap in order to have access to the bone. When do I do that? I do that in every single procedure that's related to the bone. So give me an example, Dr. Basim. Well, it could be implant placement. It could be crown lengthening. It could be all on 4 or all on X. It could be sinus augmentation. It could be ridge augmentation. It could be extraction of a tooth. So every one of these, I want definitely to have access to the bone. Like in this video that you're seeing right here, what we are planning to do is we're planning to do a bone augmentation because we have a vertical defect on that tooth, the lower right canine. So basically what I want to have a very clean, full thickness flap exposing the bone and not leaving any periosteum on the bone. And why do I do that? I do that because I want to do a bone augmentation procedure. And you can appreciate that defect. Again, thanks for Dr. Saeed for offering this video, that we are going to do a bone graft on this tooth, and we are going to do what? We're going to do a bone augmentation. So why is a full thickness flap here is important? One important thing, and in the future, I promise we're going to talk about bone augmentation at some point. Okay, but the whole purpose is to have a clean full thickness flap, because if you don't have a clean full thickness flap, what do you have to do? You have to, you are going to thin the periosteum, leading to possible necrosis of the flap. And if you're using a non-resorbable membrane, you're going to end up with exposure. So what should you do in this case? Basically, try utilize the better instruments that allows you to elevate the flap in a clean way. What do I like to use in those cases? I like to use sometimes like a straight incision or an incision using my blade all the way to bone. And then I like to retrace my incision with any kind of knife, like a modified Urban instrument, to retrace my incision and be able to lift my flap using a Glickman elevator. So in all these cases, I want to do what? I want to have a full thickness or a full access to the bone. I have to see the bone, so there shouldn't be any periosteum on the bone. However, in some cases, we don't have to have a full access. What are those cases? For example, in soft tissue augmentation cases, right? When soft tissue augmentation cases, I want to keep a periosteum on the bone. So I don't have to fully access the bone. I want to keep a layer of periosteum on the on the bone. So basically, I take something called a split thickness flap, which is basically you take a harvest or you remove the tissue or you elevate the flap. In this cases, I'm just showing you the like one aspect of how we might be able to do not like to harvest a free gingival graft, but it's the same concept. Basically, you remove, you trim, or you harvest the free gingival graft in a partial thickness way, right? In a, I would say, like you thin, you make sure you have a 1.5 millimeter thickness, and then you leave the rest of the rest of the connective tissue attached to the bone. Let me give you another example. In this case, there is a limited amount of keratinized tissue around implant that was placed on the lower right side. So here, we highly recommend to change or to alter the quality of the tissue that we have around this implant for a longevity or better predictable outcomes, right? Or a long-term predictable outcomes. What do? We do a free gingival graft. Basically, what I harvested from the roof of the mouth of the patient, now I have to create a recipient site right here on the implant. And when I talk about the recipient site, basically I'm doing a partial thickness flap on that site by lifting part of the soft tissue and keeping the periosteum, as you see right here, still attached to the bone. Why I'm doing this procedure right here is basically I want to keep that periosteum to nourish and to be to be like a source of supply and source to supply that graft that I'll be placing here with all the components that allow that graft to survive. So basically, I create a split thickness, I split the soft tissue using my 15C, and then I do what? I keep part of the periosteum still attached on the bone, and then I put my graft, and then I suture it up. Dr. Basma, what if I accidentally open a full thickness flap while I'm doing a free gingival graft? All the literature says that you will have good healing still with a free gingival graft that's only placed on bone, but it's going to be longer healing time because of the limited supply to nourish or to keep that graft alive. So this was based on the amount of bone exposure that we have. So if we are fully thickness, that means we have to access like a sinus lift, like the ridge augmentation, like implant placement. If we have to be split thickness, like if we're doing a free gingival graft, for example, on one side, we split the flap and we keep part of the periosteum on the bone without exposing that bone. When we talk about placement of the flap after the surgery, it's basically, what are we doing? For example, there are some cases where we're pulling the tissue down, right? Or coronally. More coronally, if you think about it this way, I have a tissue at an apical portion of the tooth, and I want to push it more coronally. Where do I utilize this kind of graft? In soft tissue augmentation. Basically, if I have a recession, and all what I have to do is to advance the tissue in order to have a root coverage procedure, for example. So if I am able to do that, that means that this is a flap that I'm currently advancing in relation to the cement to enamel junction. Okay, so here in this case, I have a root that is exposed and I want to advance the tissue coronal to the cement to enamel junction, and then I suture it up in order to have a root coverage procedure. However, in some cases, like what we discussed last time, in some osseous surgery, in some crown lengthening procedures, we do some like subcrestal incision, as we discussed, in order to have the positive architecture for everyone who was there last time. And then the tissue should be placed apically to the position of, apically to the CEJ or apically wide, in order to get rid of those pockets that the patient is having, or in order to give the patient, to give the restoring doctor a more leeway to have enough tooth structure or enough ferrule to be placing a crown. So we have, according to what are we doing with the flap, a coronal advancement in case of we're doing soft tissue or root coverage procedure, or apical placement of the flap in case we're doing crown lengthening and osseous surgery. So if in cases where we have osseous surgery, we have to get rid of the pockets. In cases where we have crown lengthening, is basically if we have the crown margin is very close to the bone. So basically we end up moving the bone 3 to 4 millimeter apical to the future margin of the crown. And then we place the flap apically. Why? To be able to restore that tooth. Then we move to the last classification of flaps, which is basically management of the papilla. Well, Dr. Basma, there are some patients with a very high smile line. There are some patients that if I open a flap, and they are very picky. If I open a flap, and there is a small black triangle that's created, we are going to be in trouble. What do I do in these cases? We do a type of incision that's called papilla sparing incision or papilla preservation incision. What does that mean? That means I am doing a big augmentation in an aesthetic zone that I don't want to be dealing with anything related to the papilla, because I know, as I mentioned earlier in the lecture, if I open a full thickness flap, including the papillas, and I put it back, there is a high risk that there's going to be a slight papilla shrinkage, like what you see on the right image. What you see there, or on your left image, what you see there is a small black triangle that usually bothers a lot of patients, especially if we as dentists created, right? Like in this case, we're doing what? We're doing a bone augmentation, but at the same time, I'm trying to preserve the papilla. Basically, I do 2 vertical releasing incisions away from the papilla on the line angle of that site, and then I do my augmentation. What is the advantage of this? Is that I was able to have a better access all the way to the most apical end of my site or my flap. And at the same time, I was able to coronally advance that site or that flap. And at the same time, I didn't include the papilla. So I don't have any risk of shrinkage. I'm certain that there are no changes are going to happen for those papillas, no shrinkage. So that means I use this papilla sparing incision only in cases where there's a high risk or with the patient with high maintenance where he is very picky about aesthetics. As a summary for all the flaps, and then we move to the second part, and then we end with the surgical principles. Flaps, as you saw, it's not as one flap design that I can utilize for every single procedure, right? It's depending definitely what I'm planning to do. Am I planning to access bone? I have to open a full thickness flap. Am I doing soft tissue graft? Then it might be either a split thickness or it could be a coronal advancement. I'm doing osseous surgery. It could be an apical position. So we were talking about intrasulcular incisions, vertical incisions, crestal incisions. Let's talk a little bit about what are those incisions, okay? So I'll be, again, when I'm showing you this video, just to try to show you what is a vertical incision. So this is a vertical incision right there. Again, I place it, let me go back. I place it, a vertical incision is placed on the line angle of that canine, okay? I go on the line angle, I didn't include the straight buckle, and this is called intrasulcular right now, where I'm inside the sulcus in order to split that soft tissue away from the tooth. Now what I'm doing is I'm reflecting a full thickness flap. Why is that? Is because I want to have a good access, because there is a tooth that has a big apical lesion. I'm going to take it out, and then at the same time, I'm going to do a big augmentation. So you see right here, I have to have access all the way to the apical end of that site. So I have to have a vertical incision that gives me that access. And then after I do that, I make sure I remove all the granulomatous tissue. I make sure I assess the defect very well, and then I go with the augmentation procedure. So basically, my incision right here, if you see, there was a vertical incision on the canine, there was a intrasulcular incision or in the distal portion of the canine, there was an intrasulcular incision around the canine also, and the central, and on the lateral. All what I wanted is to have a good access on the side closer to the canine. And that's the reason, for example, why I put my vertical incision on the distal of the canine and not on the distal of the lateral on the other side, or the left lateral, right? Because my defect was closer to the right side of the patient, was closer to the canine. So that's why the right canine, that's why I placed my vertical incision on that side. Why? Because I know I will have better access if I place my vertical incision on that side other than if I place it on the other side, right? So this is how we should all utilize our procedures, right? Basically, create a vertical incision closer to the site that we are going to be dealing with. Because in this site right here, if I have, let's say, this problem on the on the left central that you see still in this picture, what do I have to do? Maybe my vertical incision is going to be moved from the canine area into the lateral area, or the left lateral area. Why? Because I have to access the apical end of that central that I have to be dealing with. So this is a full thickness flap. This is that includes vertical incision, and that includes what? Intrasulcular incision. What is that flap called? This is called a pyramidal flap. One incision and intrasulcular incisions. And then we talk about the pouch, which is basically a certain, like a tunnel procedure that we access or we split the tissue without opening any flap. Basically, there is no incisions here. All what we have is a split thickness or a full thickness. I don't want to say split thickness, or we're splitting the tissue in order to allow to insert the soft tissue graft in order to do this root coverage procedure. So basically, what I do in this scenario is there's no incisions, there is no flap design here. All what we're creating is go inside the sulcus and splitting the tissue in order to be able to coronally advance the tissue or the flap, and at the same time to be able to insert a soft tissue graft and have predictable root coverage. And this is again called a tunnel technique or a pouch technique. And that's how we're gonna end. So we all saw the different kind of incisions. We all saw the different kinds of designs, of flap designs. All what we have to understand is every procedure has its own design, have its own incisions that you have to utilize, and at the same time, be able to understand the side that you're dealing with from the beginning. Because once you understand, once you have a reference, okay, I have a fistula on this tooth, now my vertical incision should be here. Or maybe I should include more tooth intrasulcular incision to have a better access. So all these are very important to understand. At the same time, we should understand that anytime I'm doing a full thickness flap, my incisions should be firm all the way to the bone, right? If you do an incision that's barely in the tissue and you try to elevate a full thickness flap, you're gonna be tearing the flap and creating a split thickness in some areas, leading to a necrosis if the flap is very thin. So you have to have a very firm stroke whenever you're using your 15C if you're going all the way to bone. Again, when do I go to the bone? In implants, in implants, in bone augmentation, in sinus augmentation, in extractions, anything that's related to the bone. Okay, so again, keep in mind your vertical releasing incision should always be on the line angle of the tooth. That it's not in the middle, it's not in the it's not in the it's not on the papilla. And if you remember from the video that I showed you, or from the pictures that I showed you earlier, my vertical incision is never on the site that I'm dealing with, right? Like for example, in that video, I was taking the lateral incision out, the lateral tooth out, but my vertical releasing incision was on the canine. Why is that? Because I want to stay away from that site in case I want to do any grafting. I don't want my incision to be on top of the grafting. Okay, so always locate your vertical incision at a distance from the area or from the lesion that you're augmenting. Let's say you're augmenting a lateral, or you're augmenting, let's say, tooth number, the lower right canine. Your vertical incision has to be on the at least one tooth or two teeth away from the site you're dealing with. Okay, also it's very important that your vertical incision is at the line angle. It's not in the middle, it's not on the papilla. Okay, if you are reflecting a full thickness flap, the periosteum is integral part of the flap. Make sure what you don't have is you don't have periosteum still on the flap or if you're doing a bone augmentation procedure. Have a very clean reflection, because most of the time the tissue, after the patient lost his teeth for a long time, the tissue is very thin. If you're trying to reflect the flap to do a bone augmentation, especially a vertical ridge augmentation, and you didn't open a clean soft tissue graft, that's one, a clean flap reflection, you're gonna end up with thinning that flap, leading to necrosis, leading to what? Leading to exposure of the membrane. And if this happens, definitely in some membranes, that's a failure if it happens at an early stage. Also, whenever you're trying to reflect or to do a vertical release, a vertical incision, your incision should always have a wide base. This is very important. What does that mean, a wide base? Your incision should never be triangular like this. My incision should go from the teeth and flare laterally. Why is that? Because the wider the base is, the better blood supply to the flap. Because if I do my incisions approaching each other, like in this shape, like here, the teeth are more coronal, and my incisions are going to each other. What will that create? That will create a minimal blood supply to the flap, okay, leading to a possible necrosis of the flap. So my releasing incision should always be what? Should always be flaring, or should to have a wide base to have a better blood supply. Again, I acknowledge Dr. Said for sharing some of his cases, and I want to thank you for your attention, and it's time to have any questions. So thank you so much.
Hi.
Yes.
Yeah, thank you, Dr. Basma. That was a wonderful session. And we do have a lot of questions. Some of this are directly related to the case, and then there are some general questions also. So we'll be picking up both of them. So I'll just take up one by one. The
Yes.
first question is with that the audience is asking is, in which indication do you recommend tunneling flap procedures?
Excellent. So as I mentioned, the tunneling procedure is only we do it if we are doing soft tissue graft. So basically, if we have recession on some teeth, okay, if basically minimal recession of the teeth, I like, as I mentioned, as I showed in the video, I go inside without lifting any flap. I create a pouch inside the sulcus, okay, in order to split and to release the tissue from all the muscles that's going to pull it down. And basically, I'll be able to insert the soft tissue graft or whatever graft I'm using, if it's an allogenic, if it's an autogenous graft, and at the same time be able to suture it in a coronal position to the CEJ. So basically here, I didn't use any incisions. I did what I used is just a pouch to free the tissue and to coronally advance it. So mainly, if I want to answer very shortly, mainly for soft tissue augmentation for root coverage procedure. That's when I use the tunnel procedure.
Right. Thank you for that, Dr. Basma. This question, I'll put it up. Let us see if we can understand this. So the question is, what about the fistular opening and lining? Do you advise curettage? So maybe this is related to the case that you presented.
Yeah, I'm sorry, can you repeat that?
What about the fistular opening and lining? Do you advise curettage?
Yeah, if I have a fistula, I like always to do a curettage. You know, like especially if my attempt is to take this tooth out and clean everything, and if in one scenario, especially if I'm planning to place an implant. If I'm planning to place an implant in the future, I always take the tooth out, open a flap. If the fistula is very big, clean everything, and then make sure I cleaned or removed all the granulomatous tissue. I place my bone graft, I place my membrane, and then I close it back. Do I do that in small, in cases we have a small infection? Definitely not. I like most of the time in my extractions, if I'm not dealing with a big infection, I like to keep it flapless. Basically, I don't like to open any flaps. So basically, I take the teeth out, I clean very well, I curettage, and then I place my bone graft. But definitely, if I want to give one advice here, anytime you have a periapical infection on the x-ray, please take your time. Sometimes I spend more time cleaning that infection more than extracting the tooth. Because if you leave part of that infection and you place the bone graft on top of that infection, you come back, you will see that most of the time the bone graft is not going to heal well. You come back and then the whole bone is like mush. You just take it out. You can excavate it out also. So you're going to lose time. You're going to lose products. You're going to lose on this procedure. So take your time whenever you're curettaging the defect.
This question is also related to something that you were to say, though what the doctor wants to ask is, what type of flaps do you recommend for apicoectomy?
To a what?
Apicoectomy.
Apicoectomy. Yeah. So apicoectomy is a completely different procedure. You know, like if you want to utilize what I discussed today, you should use exactly the same, a pyramidal or a trapezoidal flap. You place a vertical incision, okay? And then you do what? you do intrasulcular to have access all the way. But again, personally, what I like is if I'm able, based on the X-ray, to measure approximately how much, what's the height of the tooth. Let's say I have a 25 millimeter tooth from the incisal edge all the way to the apex. Sometimes I try to utilize just an envelope flap there without going into the sulcus. So basically, I measure 4 or 5 millimeter below the gingival margin, and I do a small window there. I access the apex, and then I clean it up and I close it back. What did I create here? I was able to do my epiectomy. I was able to close it back, but at the same time, I didn't do any incisions on the papillas, any incisions that might cause a shrinkage or aesthetic problems. So highly recommend, try not to open a full thickness flap or including the margin of the tooth. Just make sure that you go apical to that, apical to the gingival margin. Don't go on top of the apex. Again, your incision should always be at a distance from the site you're dealing with. 3-4 millimeters, place your vertical incisions and horizontal incision, open a window, clean it up, and close it back.
Sure. And what flap would you recommend for an impacted third molar extraction, Dr. Basma?
Impacted third molar is easy. All what you have to do is a crestal incision on top of that site and place 2 vertical incision in the back, mostly towards the buccal. Definitely never place incisions vertically on the lingual, because in that site we have the lingual nerve. So what we have is we place a vertical incision, a crestal incision on the crest, and then we place 2 vertical incisions. In that area, we don't have any anatomical structures that I might care a lot about. So basically, I open a full thickness flap. When I have those 2, especially the distal one, you know, if you can go with an intrasulcular incision on the first and the second molar, that's fine, okay? But you have to place a vertical incision way behind or more posterior to where the apical tooth is going to be. So do your vertical incision. Once you do your vertical incision, the ease of flap management is going to give you a good access to the site.
Right. I think you discussed this during your lecture also, but anyway, for the sake of repetition, the person is asking, what are the main advantages of an envelope flap?
Envelope flap. So basically is like, are you talking about the tunnel flap?
So the question only says envelope flap. They haven't specified.
Okay, so I'm gonna answer this as if it's a tunnel flap. And please,
Right.
if anybody, if the person who is asking this question can give us more on the envelope flap. So the envelope flap is basically, if it's a tunnel flap, is the advantage is that if I want to pull to a coronally advanced tissue just a little bit, all what I have to do is basically create a pouch and not be dealing with opening a full thickness flap or a split thickness flap, only creating a pouch and inserting the soft tissue graft, and at the same time advancing the tissue. If the envelope, what he means by the envelope is when I'm harvesting the soft tissue graft from the roof of the mouth, that is completely different. Sometimes what I do is I do my one incision on the roof of the mouth, on the palate, and try to harvest that connective tissue from underneath the flap and take it and place it in the grafted site or in the recipient site and close back the roof of the mouth. So what is the envelope flap allows me? Allows me to, like in this case that I showed you earlier, I harvested a free gingival graft. I took it all and I kept the palate exposed. Sometimes we do like an envelope flap where we basically do one incision. We take a CTG from underneath the epithelium there, and then we close it back. So basically as if nothing happens. The advantage of this is this create way less discomfort for the patient during the healing time. That's the advantage of that.
And we'll take one last question, Dr. Basma. This is more of a general question on what are the red flags or what are the special things that we need to watch out post flap surgery. which would indicate that the wound is not healing properly or there is something to worry about?
That's an excellent question. Depending on what procedure you're doing, okay? Let's say if you're doing a vertical rejuvenation, okay, or a bone or a horizontal rejuvenation, your flap at 1 week or 2 weeks has to be closed. If it's open, that means there was a problem with a couple things, with the release or with the incision design. Okay, let's say if you're doing an extraction, patient came, if you put the bone graft, patient came with a dry socket, there's a problem. Okay, if you are doing a soft tissue graft and you did any kind of autogenous or allogenic soft tissue graft, and at 2 or 3 weeks the patient come with an exposed graft, that means you had a problem with your incision or with releasing the tissue, the same. So the biggest, this is like minor failures of the flaps, right, of the incisions or of the procedures. When it comes to bigger is when we talk about infection. Basically, if I take the tooth out and then I do a bone graft and the patient comes back and there is pus coming from everywhere, that's a problem. If I'm doing a sinus lift and I see a pus, that's a bigger problem, because what should I do next? I have to go in and clean everything out back. Okay, so this is what usually is the most annoying part, because this will also create a scar tissue, making the second attempt even harder. Okay, so make sure surgical sterile protocol and follow those steps, especially from the start till the end. If you understand today your incision design, and next time you understand how do we close those procedures, when I talk about sutures, you definitely will have predictable outcomes.
One last minute question that has come. So I'll since we have a little time, I'll just take that up also, Dr. Basma. So the doctor is asking, what is there anything special we can do in terms of improving the sensory regeneration of these flaps?
Regeneration of these
sensory
flaps?
In the sense they can sense in terms of there is some loss of taste and all these things. So if there something which we can do for sensory regeneration?
Oh, like for example, if we hit the nerve by mistake?
Yeah.
Okay. So the best thing to do is to avoid hitting the nerve. This is the most thing. How do I avoid that? Just to answer this question from the beginning till the end. How do I avoid that? Is basically having all the standard of care procedure, like have a CBCT and be able to know what I'm dealing with, right? Because there are 2 ways that I'm hitting a nerve. It's either in the mental foramen or in the IAN right here, right? Those are the main 2 things that the dentists are high risk that we're going to cause some paresthesia or some numbing there. So one is, if I understand the CBCT, I will be able to know how much height I have bone, so I will respect that and try to avoid hitting the nerve. And 2 is, but when I'm opening a full thickness flap based on the CBCT2, I will be able to know estimately where is that. Let's say I see on the CBCT that the mental foramen is apical to the second premolar. Then I know that when I'm opening my flap, it's in that area. Most of the time, the highest risk is whenever we are doing 2 procedures. One is rejuventation, because we're doing we're doing the periosteal releasing incision, and 2 is when we're doing the soft tissue graft in that area too, there is a high risk that we might hit the mental foramen by mistake. What do I do in these cases? Sometimes I give patients vitamin B supplements. Sometimes I give patients like Norbion. Sometimes I just depending on how much, I just watch it. I give patients some medication that helps at the time, but most of the time the sensitivity is gonna come back unless it's completely cut. So what do? I just, every time the patient comes, I try to figure and draw what's the area of numbness is going to be. If the patient tells me, well, I feel all of my chin, but I don't feel my lip, that means the nerve endings are the ones that are affected here. So I just tell the patient it's just a matter of time that it's going to come back. So keep and watch, and definitely give some supplements that will help with the healing of that nerve in that time, especially at the beginning.
Sure. Thanks a lot for all the information, Dr. Basma. I'll hand it over to Dr. Gulshan now.
Thank you so much, Dr. Manish. Well, with this, we come to the end of this very educative and interactive session. And I'm very sure that our audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Basma for sparing his valuable time and being with us here today. I would also like to thank our educational partners, FDC Limited, and CME partners, Parent Communication, for conducting of the program. Happy weekend to all until we meet for the next webinar. Thank you so much.
Thank you, everyone.